Well, thank you. And actually, that was a great ending because you segued into an elephant that I want to put on the table here. We've talked about 4 different types of approaches to large simple trials, ranging from one that really began over a decade and a half ago. You know, it's ancient in comparison to what you were talking about trials that are ongoing. And one thing that always amazed me was this came out of the use of kind of NIH concept that evolved from the SOLVED trial, which was a fairly large heart failure study of enalapril hooked up to a registry, but it was also a pretty simple trial. And the goal was to get down to 1-page case report forms. Didn't quite make it there, but came close. But you ended with a discussion of the other elephant that I think is in the room with all of these trials, and it's informed consent, and its process, and its regulation that's associated with informed consent. So we've talked about randomization. We've talked about placebos and perhaps their importance versus active controls. But we haven't talked much about informed consent. You raised the difficulty, so I'm going to ask quickly as other people come to the microphone, the rest of the 3 panelists to talk about it. You have unique issues in the pediatric population, and you got, quote, HIPAA waiver. Who decided on that? Does the IRB decide on HIPAA waiver? And you also had waiver of informed consent to get some healthcare information for research purposes, it seems. So talk a little bit about kids in these trials.
The challenge for us isn't so much with a waiver of authorization, we can get limited personal health information. You do need to get the outcomes that we need from the electronic health record to do medical record review. You do need written consent. And I have argued with our institutional review board about what they consider is written consent and from who. And I think that's the challenge, is that in order to go into the electronic health record to do anything other than the discrete, looking at the discrete fields and data pools that are de-identified, it requires written consent. And so in this one trial in STAR, where we are doing, so we have children that range from 6 to 12 years of age, we have to both get written consent from the parent, but written assent from the child after 8 years of age to agree to be a participant in the intervention. And they won't, there are a lot of restrictions around getting emailed consent forms or faxed consent forms or telephone. So it is a challenge. I don't know that I have the answer to it.
2 quick comments from Niteesh and JoAnn, and then we'll head back to the microphones.
Yeah, so the only things I'd add, and Elsie and my trial are perhaps more similar in a way than PJ's and JoAnn's trial. And the distinction that we may need to think a little bit more about is between quality improvement, post-registration kind of activities, and pre-registration, safety, and or efficacy kind of activities, which may have different issues for both placebo control and for consent. In our case, as I mentioned, we were making insurance benefits more generous, and that's really all that we were doing. And when we do other adherence improvement studies, which are intending only to reinforce what prescribers have already provided to patients, and patients in theory have already consented to receive, the risks are a whole lot lower.
But you were still looking at major vascular outcomes.
Absolutely, but here the intervention itself was changing copayments, and no one was worse off, right? Everyone got their insurance. We have no ethical or other moral obligation to sort of say you must have full coverage for everything in healthcare, and that was the way the IRB viewed it as well. So I think that's a distinction from some of the other interventions. One quick last comment is that I'm involved in a bunch of other trials in which we are using some of these other consent mechanisms, and there are cheap ways to do this, IVR and other based things, which can be implemented relatively inefficiently, completely remotely, and need not have paper consent, except in those states in the U.S. which still have those regulations.
JoAnn, consent a problem for you?
Well, it is a challenge because the consent form is very long. The HIPAA portion of it is also very long.
How many pages?
It's 8 pages.
Yeah.
And we do have the IRB's approval to get consent through the mail, but there's a drop-off in the people participating in the phased-in, multi-phase recruitment process. A lot of people are a little intimidated by a consent form that long. However, I think that one big advantage we have in Vital is that we're allowing everyone to take up to the recommended dietary allowance of vitamin D. And we make it very clear that people can take as much vitamin D and as much of it, they can eat as much fish as they want. And, there's no evidence yet that having higher intake of vitamin D or fish, will confer greater benefits. That's the purpose of the trial. If we were, and some trials will require that participants stay below the RDA, and that becomes a bigger issue for getting informed consent.
So Ralph Horowitz, actually your question about informed consent led into a question that I had as I listened to these 4 studies, all of which, of course, are treatments that are generally out there, already well accepted in the medical community. But you touched on the fact that the issues range from eligibility to recruitment to informed consent to the complexity of the intervention to the outcomes measured. And I was left wondering what we mean now by simple in the large, simple trial context. Maybe it's like pornography, you know it when you see it as simple, or maybe there is no easily defined definition of simple here, and the bright line between simple and complex is not so bright at all. But I'd be interested in hearing, given the range of complexity of these 4 trials alone, how our colleagues think of the distinctions between simple and complex here.
And the only comment I'll make is to cap on that word simple, because we talk about LSTs, and what I would like to see is an SSC, a short, simple consent form, matched to the LST.
Right.
So that was the only point I was trying to make. JoAnn, do you want to address that?
Well, I think that there isn't a terrific definition of a large simple trial. Compared to most trials that are being done, this is all of the trials that were presented are relatively simple in terms of the requirements for the participants. The participants are not being asked to spend an inordinate amount of time in clinic visits and going through really extensive testing. Relatively simple for the investigators involved in terms of what's required. I think each showed that very clearly. Relatively simple in terms of the length of the forms and usually very cost effective, and large in terms of being able to get an answer in a very cost effective way. But I personally think that it is extremely difficult to give a 1 or 2 sentence definition of what a large simple trial. It is a little like you know it when you see it. You know when you see a really complex trial that is not a large simple trial.
Yeah, 1-page case report form. So anybody else want to make quick comments? We got a whole rash of questions out in the audience. I want to get to them. Are we okay? Okay, let's go ladies first over here.
Hi, my name's Nancy Roach, and I am with Fight Colorectal Cancer. I'm a patient advocate. And on the issue of waiving consent, I'm not really a fan of waiving consent, but I'm also not a fan of what passes as informed consent. And there really needs to be, it's more about risk management for the institution. And I think that is a fundamental flaw with our research system. I was hoping that OHRP would have acted by now on the proposal that they floated out last year, but I haven't seen any traction on that.
I agree with that, and I know Mike Lauer and I have had a lot of conversations about some of the registry efforts that we're doing there, and NIH is making efforts to try to look at things in a little bit more rational fashion to avoid excessive paternalism. I mean, that clearly is an important issue, but I think the pendulum swung too far and it's coming back down. Bob Temple?
Can I respond to that first?
Yes, PJ, and then Bob.
I appreciate you getting up and saying the issue that not getting consent makes you feel uncomfortable, and I think it's true of most people, but part of it is because that's the world as we've seen it and know it. I think we do have to guard against paternalism, but I think there's a lot of times where we're imagining something's happening with getting consent when it's really not. Right. So as an example, in the case that I was talking about where everyone who, a physician orders blood, they're going to get blood. And the way that all hospitals work right now is you'll get the oldest blood. But you are going to get blood. So to say to people that we're now going to actually enforce that you're going to get consent to say you'll either get the old blood or you'll get the newest blood, does it really make sense? But what it does do is it'll increase the cost and make the research a lot less likely to happen. As a physician, I want to acknowledge that there's lots of times when I'm involved in patients' care where I'm actually not certain what's the right thing to do. Or there's been times when I felt certain and later discovered with good research that in fact I was wrong. And in fact, what I put out, what is really unethical for patients is not getting good research done. And that is the biggest risk to patients. And so that I think there are times when consent is really not necessary because the likelihood of any harm to a patient is either doesn't exist or it's negligible, but what it will do by getting it is actually impede the likelihood of getting research done that will help patients. That being said, I'm not saying there never should be consent, but I think that right now, as you said, we're so far on the pendulum, we're not being rational.
I agree.
That's a really good point.
The consent issue is particularly important, obviously, for cluster randomized trials where it's not even easy to imagine what consent would be in that setting. The second thing is maybe they should be called simpler trials, not simple. And the third question is about the HOPE study, which is how did you get a 99% follow-up rate? Anybody who's been reading the papers knows that in large, carefully done, complicated or simple trials, we're seeing 90% obtaining vital status. You had 99%.
PJ,
What did
you
they
want me
do
to
to
take
do
that
that?
question? Because this was something that up front was an absolute passion of Salim Yusuf, I have to say. And the committee structure was set up parsing out the international nature of the trial. And PJ hit a very important thing that we don't always see. This was a good old boys club that did this study. It really was people that knew one another, that had worked together on 3 or 4 seminal heart failure trials. And so from the very beginning, we went out knowing that we needed vital status on everyone. Now, what else is important? We weren't hampered by a lot of the restrictions that come with informed consent now about how to follow patients up. And so we used all the countries' death indexes. We used detectives. We sent out people into the fields. And, you know, in the United States, it was a huge challenge. But don't forget, this was done, you know, over a decade ago. And we could get away with doing some of those things. I don't know, do you want to add any more, PJ?
Well, the thing I just add, Bob, is that it's not a unique example for the Population Health Research Institute. In our institution, you know, we've had probably 25 large trials within the last decade. I can't think of a single one we've had less than 99% follow. But it's the issue that is a huge focus to us because we recognize that it profoundly impacts applicability. People doubt your results. It's been a big issue recently in cardiovascular trials with drugs in your institution where people have seen very impressive results and there's questions about indications because of loss of follow-up. So I think you just have to put in place every measure and get people committed at the word go that in fact follow-up has to happen.
Yeah, well, we're going crazy with this because we're seeing follow-up below 90%, partly because registries are harder to get at. It's worth writing this up, you know. Maybe you already have. But that experience on getting that sort of follow-up is worth telling people about because companies are getting into terrible trouble.
We got a sidebar from Dr. Califf here. Shout. Okay. Right. Rob made the point off the microphone that the problem is the U.S., by and large, because OUS, it is sometimes easier to capture this information. Now, I will disagree with that. We're closing down the RED HF trial, which is a darbepoetin and anemia and heart failure patient trial, and we have some 14 patients where we think we know vital status. Over in France, major problem. Germany, major problem. Poland, major problem, where because of withdrawal of consent to participate in the trial, we cannot go further to ascertain what we believe we know as vital status. So it's not it's not only the United States, but I do agree some with Rob. Let's go to the middle.
Can I just say one thing? We're now informally telling companies not to do trials in countries that won't let them follow them up if they withdraw consent.
So with us, our problem, yeah.
You can use, well, that'll be fine.
Bob, the other problem is the rules change. You start a trial, and 6 years later, the rules are different. Middle microphone here.
Yeah, hi, John Steiner from Kaiser in Colorado. You know, we talk about a lot of the advantages of doing trials in live delivery or payment systems, like the accessibility of data and the ability to enroll the organization as a stakeholder. And lastly is the ability to translate the findings more rapidly into practice. And in that context, I actually have a question for Dr. Choudhry, which is one of your last points was that Aetna is now instituting this policy of waiving copayments for essential drugs. A trial purist might argue that that's premature. The major study outcome was not statistically significant, and the cost differences sort of hovered on the border of significance. So are they implementing evidence-based practice, or are they jumping to conclusions? What do you think?
So ultimately, I'm not paying the check, they are, but that's a great question. And I think the important distinction here is, again, about the nature of the research and the research question we're talking about, which is in the post-marketing quality improvement setting. So if you ask, as I do frequently, colleagues in the business community, you know, what do you think about a p-value of 0.05? And they say, well, you know, they understand what that means, and we all understand where that comes from or doesn't. But they say, look, I'd be willing to take a wager of being right 8 out of 10 times. And so maybe a 0.2 or 0.21, as was the primary, might be okay. And so that's as a general construct of how decision making is made. The second is that, you know, the things that were non-discretionary, which were pre-specified, you know, were reduced. You're absolutely right. And from a pure cardiovascular trial perspective, we presented this at the AHA, and Eric was our discussant. You know, it was a null trial. But in its totality in a quality improvement space, I think it's a slightly different result, and that's important to remember when thinking about results like this.
Well, and I just would offer for our consideration here that this notion of different sort of Bayesian thresholds for making decisions is actually extremely relevant. In my more cynical days, I feel like P equals 0.49 is sometimes the decision threshold operationally.
I agree completely, and I don't want to get another one of my elephants on the table, but the holy grail of 0.05 is kind of one of them, no question about it. Question over here.
Hi, I'm Dave Clifford. I'm a consultant today working on behalf of the Kauffman Foundation. There's an investigator there named John Wilbanks who's been doing quite a bit of work on a process called portable legal consent, where he's established a means whereby an individual can consent rather than to a trial to a data repository. And the framework is such that once they have established a consent relationship with this data repository, investigators can then access that data for secondary use according to the terms of the repository rather than the terms of the trial. It's an 8-page consent form, very similar to the one that you would find in a trial. Not great. One of the things that he does in addition to providing the patient with a consent form is in order for this sort of broader consent to be established, he requires that people consenting to this repository watch a video explaining what they've actually consented to, and then are able to fluently answer a series of questions regarding what it is that they've consented to. And if they can't answer the questions in the affirmative or correctly, then they can essentially consent to the broader research scheme going on. It's an interesting model. It's used to establish what he's considering to be a healthcare commons. There was recent TED Global talk about it, and if it's something that you're interested in learning more about or using as a model in your own organization, I would suggest that you either talk to me or him at some point.
Definitely something to pursue. We have our data repository being Epic. When your BMI alert came up, I had to smile because it kind of looks like one that we have there in the Epic form. But if you get admitted to the hospital through the Heart and Vascular Institute at the Cleveland Clinic, we have a consent waived research program going on where we can utilize that Epic-based data record for doing outcomes research. Ralph, did you have another comment or another question? other people in the audience that, yes, one more comment?
I just wanted to add that there was some interesting research that Valerie Rohrbach from IOM is aware of, as well as some other people on the ECIC panel, which is the Evidence Communication Innovation Collaborative, which is an IOM panel that's part of this roundtable as well, where they showed that the majority of people, I believe, and I don't want to misstate this, have the expectation that data is fluidly going between practitioners and researchers in order to advance care. So there's the expectation that I think that most of the people in this room have, which is that privacy is the leading concern, consent is something that we have to get from patients, and then there's the real world expectations of individuals, which is generally operating under the assumption that the system is getting better, and it's getting better using data, and it's getting better in part using their data. And that's something that most people seem to be comfortable with from some of the survey research that's been done on this topic.
I think we have time for one last question, and then we'll break. Yes, sir.
Yes, Henry Ford discovered that if you make cars all the same parts, that you could produce it a lot cheaper. And I imagine electronic health record vendors have discovered the same thing, that if you don't change your product, it's easier to maintain it. Yet, if you look out into the future and you see where is all of this evidence-based practice information coming from, the patient-centered outcome research coming from, we hope a lot of it's coming from electronic health records. So I would ask Elise, and maybe you, James, is it easy to work with a large electronic health record vendor to get your research data collected through that, as opposed to having a separate sheet of paper or a different computer where the people helping the investigator have to record that about their patients?
No, it's very hard. It costs a lot of money, and it requires a tremendous amount of IT support to do it. But you can do it, and I'm speaking specifically of Epic. It can be done. But there is reluctance to making it something that's simple and easy to do. But there are other things coming out, including the IBM Watson projects, for example, which I think are going to have a great role in this. I think we're going to have to stop here so we can move to a break. I want to thank everybody. And Mike Lauer, the only elephant I didn't put up on the table was the relationship of registries to large, simple trials. Now, we talked a little bit about some of that earlier, but I think that's an important thing not to forget. Thank you all.